Good to see you here and to see some unfamiliar faces. I'm Carol Runyon. I'm the Director of the Program for Injury Prevention Education Research and a faculty member in the Department of Epidemiology. This seminar today is co-sponsored with the Department of Community and Community and Behavioral Health, CDH, and we appreciate their co-sponsorship. Before I introduce today's speaker, though, I want to draw your attention to the next one in our series, which is posted over here. On April 19th, we'll be hosting Ingrid Binswager, who is a faculty member in internal medicine and at Kaiser, and does really exciting work on the opioid epidemic and opioid poisoning prevention. So I encourage you to come to that one and put it on your calendar. I've been reminded that I should pass around the attendance list. Please fill that out so we know who is here and also can make sure you get announcements about future seminars. And at the end, we'll be sending around an evaluation as well. So on to today's speaker. I'm very, very pleased to have an old friend. Well, she's not old.
Yes, I am.
A longtime friend and colleague, Andrea Gielen, visiting from Johns Hopkins. Andrea is professor of health behavior and society at the Johns Hopkins School of Public Health, Bloomberg School of Public Health. Got to get all those names in there right. And also for the last dozen or so years been director of the Johns Hopkins Center for Injury Research and Policy, which is only one of two injury control research centers that have been continuously funded by the CDC for more than 30 years. She's a highly recognized leader in the field and has been honored in numerous ways, and I'm not going to read the whole list or I would take up all her time, but did want to point out that in 2002 she received the Distinguished Career Award from the Injury Control section of APHA. In 2012 was cited as one of the 20 most distinguished leaders in the injury field by CDC, and in 2013 received the APHA Award for Excellence from the entire APHA. So the list goes on. In addition to being in academia, Andrea has worked in the real world in a public health department at the beginning of her career and continues to work in a practice setting with a lot of her research projects, which I think, for those of us who struggle with how to blend research and practice, I mean, she exemplifies how to do that, as I think you'll see in her presentation. She's focused, a lot of her research has focused on the development and evaluation of both community and clinic-based programs that address health behavior issues affecting women and children, and the application of behavioral sciences to childhood injury prevention on a variety of topics and topics outside of childhood injury. In fact, she's the lead author on the textbook Injury and Violence Prevention, Behavioral Science Theories, Methods, and Applications, which, as far as I know, is the only one of its kind, and a really good book. Maybe not the best bedtime reading, but it's a good book. So she's worked on a number of topics with a heavy focus on childhood injuries, and you're going to hear about one of those today. And she's been a pioneer also in the use of e-health technology as a tool for health education, and is going to share some of her experiences, war stories, whatever, with us today. So thank you, Andrea.
Thank you. Well, thank you, Carol, for that over-the-top introduction, and I appreciate it. I'm embarrassed, but I also am old. It's okay to say that. It's in the title of my talk, and you'll see why in a minute. So the question is it how do we use e-health technology? Is it possible to teach an old health educator new tricks? And the spoiler alert, the answer is yes, but we'll get there shortly. Before I get into the meat of our conversation today, I want to introduce you to our injury center briefly. As Carol said, we've been around for 30 years. We consider ourselves a collaborative of injury experts. We try to conduct innovative research. We're committed to translating that research into effective solutions, and we really enjoy training today's practitioners and tomorrow's leaders. So we welcome your collaboration and interest in the broader work of the center, which I'm happy to talk about after if you'd like to know. So what I'm going to focus on today is a little bit of an update on child passenger safety, then talk about how communication technology may help us move the needle on the child passenger safety issues that still are in the field, and then give you an example of our project called Safety in Seconds, as we moved from using kiosk technology to mobile app technology. So that's the plan. I have slides, but if you have a question or anything, please feel free to let me know, and I'm going to try to stop in time to have some structured discussion. So that's the plan, and we'll get started. So I start with this picture of Susan Baker because I'm sure she's familiar to people who are in the injury field as one of the creators and founders of our field. What you might not know is that she was the first person to identify the significantly increased risk of death to infants in motor vehicles. She published this paper in 1979. Surprisingly, the death rate is highest for children less than 6 months old than any other child age group. And this was used in many ways, and I'll tell you a little bit about the laws that came out after that. I was fortunate to get to use this information in my very first health educator job at the Maryland State Health Department, and also very fortunate to have this young man as my first son. So he's now in his 30s, so you know how really old I am. So this is the old health educator part of the talk. So what did we do with this information about child passenger safety risk? Well, we worked on community mobilization, we worked on education programs, and we worked particularly hard to try to get legislation passed. And here's a picture of our governor signing our child passenger safety legislation. Apparently, this was so long ago, we only have black and white photos. But anyway, we were successful, and the information that was coming out about child passenger safety and the impact of laws has led to today where we have child passenger safety laws in every state in the country. And this just shows you the ages that are covered in the laws. The majority are, shouldn't turn around. The most are 7 and younger are required to be in car safety seats. So the impact of this change over time in how kids were transported is really one of the important successes in injury prevention. This slide shows you the passenger vehicle child occupant deaths per million children by age from 75 to 2006. And the blue ones are the under ones. This is 1 to 3. These are 4 to 8, and these are the 9 to 12-year-olds. And what you see is a dramatic decline across each age group over that period of time. And the number of deaths has dropped from about 1,300 a year to about 600 and some a year. And that's a rate drop, as you see here, 74% for infants, 65% for 1 to 3-year-olds, 46% for 4 to 8, and 44% for ages 9 to 12. So this is certainly really good news, but we still have work to do. So what this shows is the among all children killed in passenger vehicles, what type of restraint were they in? None used, rear facing, and seatbelt used. These were the ones I wanted to call out because you can see that among fatally injured children, less than 1-year-olds, only 21% were in a rear facing seat. 1 to 3-year-olds, 25% were either unrestrained or in a seatbelt. And among the older kids, 52% were either unrestrained or in a seatbelt. So you can see there's still much to do, even though we know that car seats reduce the risk of death for infants by 71% and 1 to 4-year-olds by 54%. And again, in the second bullet, we are going to talk more about booster seats. If you compare booster seats to seat belts, they reduce the risk of serious injury by 45% in 4 to 8-year-olds. Which is good news. And we know that 98% of infants ride restrained, but only 46% of 4 to 7-year-olds are in booster seats, and 24% are in a seatbelt prematurely. And unlike the previous slide, these are from population observations, whereas the other ones were from children who had been killed. So I think this slide highlights that we still have work to do, especially in the area of the 4 to 7-year-olds. And also gives me a chance to introduce you to my my grandson. You'll get to know my whole family by the end of this talk. This is actually the other one's son. So what we wanted to do is to think a little bit about how communication technology can address these lingering problems of getting older kids in car seats. And I'll turn now to the new tricks part of the talk. And I think when we think about communication technology, there are many options. Some of the good things about thinking about communication technology and computer technology is that there are multiple options to deliver your message. You can use computers, mobile devices, the internet, and you can actually probably get more bang for your buck, because if you use something like portals and ongoing two-way conversations, you can reinforce the messages and the behaviors. You can help generate a deeper understanding of an issue. And then most importantly, I think, is that you have an opportunity to use individualized tailoring, but apply it to entire populations. So we've known for a long time that personalized messages are far superior to generic messages. Advertising has known this for a long time. That's why you get things in the mail that say, "Dear Mrs. Gielen, we have an offer for you." So we know that personalizing and tailoring is better. And it also gives you an opportunity to integrate theories of behavior change to maximize your impact. So I think for those reasons, it's important to think about how we can use computers and mobile devices and the internet. And we started the process of figuring out what to do, starting with a comprehensive literature review. Actually, this is a little bit more recent, but this was published in 2017 in Injury Prevention, where we looked at all of the articles that have been published on using computer technology for unintentional injury prevention. This was across the lifespan. And I guess it's half full, half empty. There were only 44 technology-based injury prevention studies that were eligible for the review. 16 of those evaluated what we call locally hosted software. 4 offered kiosk-based programs, 11 evaluated remotely hosted programs, and only 2 used mobile technology or portable devices. And interestingly, 11 were using virtual technology. Almost all of that was child pedestrians in virtual reality programs. So the findings were generally across the board. There was evidence of behavior change that was either self-reported or observed, and there was evidence of the possibility of changing knowledge, which you would imagine was easier to accomplish. Now, we were particularly interested in focusing on parents, and what we found was there were only 7 articles that focused on parents. The rest were either trying to train children directly, or they were being used as a training tool for professionals and how to do a certain new procedure or activity. And of those 7, 6 included car seat safety. But 4 of those, you couldn't separate out the effects of the technology intervention on car seats because they combined all the outcomes across multiple injury topics. And in the two that you could pull out the car seat information, we found one that improved self-reported car seat use and one that was unchanged. So our takeaways from this is that there's huge opportunity here, huge room for innovation, huge room for intervention trials. So the first intervention trial that we used is kiosk-based and cleverly called Safety in Seconds. Although it took us about 3 years to build it, it only takes seconds to interact with. And we delivered it in the pediatric emergency department at Johns Hopkins. And parents entered information into the kiosk, and then the little slat there is where they got a printed report that came out based on what they told us that they were doing, what they believed, what they knew about several different injury topics. We were focused on smoke alarms, poison storage, and correct car seat use. And what we found was that the intervention group had higher smoke alarm and poison storage knowledge scores. And with regard to car seats, we had a significantly higher rate of reporting the correct car seat use after interacting with the kiosk. So that was encouraging, not as far as we wanted to go. One of the things that we talked about was how can we move away from having to have this big kiosk that sits in the middle of the waiting room and has to make sure it has the right paper in it all the time, to a better kind of technology, which came a little bit later. And that's the study that I'm going to describe now, which was a randomized controlled trial that we conducted in 2 pediatric emergency departments where we were evaluating a mobile phone-based educational app, specifically focusing on car seats. I think that's another issue to always think about. How many topics are you really going to cover, and how many things are you going to ask your audience to learn about and do? So clearly we went from 3 to 1. So I think that's also something to always consider.
Andrew, how did you guys decide on car seat use as opposed to your other 2 topic areas?
Well, because we had positive results with reported car seat use, and actually because of the booster seat issue, and that we talked about whether we should be focusing on like the definition of correct use, because that's another issue is, incorrect use reduces your protection, but we don't really know how much and in what way. And so we thought you get bigger bang for your buck if you could focus on the booster seat age group. Yeah. So how does it work? Well, this is Safety in Seconds version 2.0. And the way these kinds of programs, at least how we've been using them, start with an assessment and feedback. So we did, we did a complete assessment of car seat behaviors, and I'll talk about stages in a minute, stage of readiness, knowledge, and beliefs. So you get a complete assessment of that on the app and feedback on your answers. Then you get text messages and an invitation to go to the portal. These are reminders to parents to interact with the portal and to check in on whether they've made the changes that have been recommended. And then our outcome, we did self-report on the 4 behaviors, which I'll talk about in a minute, at 3 months and 6-month follow-ups. But I think the most important thing here is like the content, these first 2 parts, and really thinking about how and what the content and the delivery of those should be. And we don't really know what's the right number of text messages, or how long should the assessment be. I mean, there's so few studies that have an opportunity to really look at implementation issues. I think there's a huge opportunity there too. And now the fun part is the theory. So hope everybody's had their lunch and isn't so we I hope you agree that if you apply behavior change theory to your messages and your programs, you're likely to get a better outcome than not doing that. So we chose to use the precaution adoption process model, which basically helps to move people from being unaware of a behavior they need to do to adopting it and maintaining it. And I'll show you that in more detail in a minute. Then, based on the little bit of literature that we found and talking to families, doing interviews with families, we made the decision to tailor on the variables you see here, which are risk perception, self-efficacy, challenges and opportunities of doing the behavior, and social influence. That these were the things that there seemed to be support for possibly influencing parents' safety decisions about their child. And then the last thing that is always important in any communication, which you probably know, is a call to action. So there should always be a call to action. In this case, we're working with an inner city population, probably applies to any population really, is that you need to make sure they know how to take the action you're recommending. So in this case, we did referrals to services for getting car seats and getting car seats inspected. And the other, I think, opportunity that you have with this kind of computer programming is to really, and this theory actually, is to think very clearly and carefully about what your behaviors are. So it's not use a booster seat, right? That's just not very helpful. So when you think about what's involved in protecting your child in a seat, it has to be the correct seat for the child's age and weight. You have to use it all the time. You have to use it in the back seat of the car. And the recommendation now is to have it inspected by a child passenger safety technician. Does everybody know what those are? CPSTs? Yeah?
No.
Okay. Child passenger safety technicians is a program that started out of I believe, the National Highway Traffic Safety Administration, where you learn all the ins and outs about car seats, how to install them, what's proper use, what are the problems that you have with certain cars, and now you can actually get a certification that you've done enough training and you've had enough hours of installing car seats that you're a certified passenger safety technician. And I believe now the Safe Kids is the organization that offers that. So the idea here is that you have to understand that people can be very different. Some people may have never heard of having a car seat inspected or a child passenger safety technician, whereas they know they should do it all the time. But they may not know what the correct seat is, right? So people are at different stages for each of those behaviors. And the stages here are unaware or unengaged, and the idea from Weinstein, who's a psychologist who created this theory, is that if you're unaware or unengaged, you should tailor the message on risk perception. And that kind of applies to both 1 and 2. Stage 3, I've heard of it, but I haven't made a decision. The idea from theory is you should tailor on self-efficacy and social influence. Stage 4, I've decided not to use the car seat. Then you really need to tailor on self-efficacy and barriers. You can do it, and here's how we can help you overcome your barriers. Stage 5 is planning to use it. Again, you continue to focus on self-efficacy and barriers to enable someone to take the action that you've now convinced them they should take. And then acting or maintenance, you tailor on reinforcement and social influence. So these were the theoretical constructs that we came up with for developing our message construct. And where we're going with this is a massive message library because the computer generates the response based on what the person tells you. And so that all happens behind the scene with the algorithms. But wait, that's not enough. Here, we also have how do you make the messages from start to finish? We start with an introduction, a stage-specific link, depending on where they are, what stage they're in, the tailored comments. We provided the underlying rationale, because one of the things we learned talking to parents is that they don't understand really why a car seat and how a car seat works in a crash. Any of you who've done motor vehicle safety have probably seen the crash test dummy videos, but parents haven't. So we wanted to provide an underlying rationale for what we were recommending, and then, as I mentioned, a call to action. So if you cross those things together, you get a matrix for the stage of readiness to change based on where they are in the precaution adoption process model for one of those 4 behaviors: correct use, all the time, back seat, and inspected. So I guess you're getting a sense that this took quite a while. Because this is what it looks like in the end, and I know you can't read it, but it's published. So if anybody wants a copy, I'm happy to point you to it. But I just want to show you sort of how that all plays out. Because when you read these articles about computer tailoring or tailoring messages, we couldn't find much guidance on, well, how do you tailor? How do you write the algorithms? We know there's a message library, but how do you get it? So this is kind of what we did. We have, specific messages depending on where we've assessed someone to be. Like I said, I'm not going to read through it, but it gives you the idea. So, my second grandson. Aren't you glad I only have 2? So just to go through now the study a little bit. So as I mentioned, we had these 4 car seat behaviors, and our hypothesis was that the intervention group would outperform the control group on all 4 of these behaviors. And we defined correct use for 4 to 7-year-olds as using a forward-facing seat with a harness if you're 31 to 40 pounds, and 41 to 100 in a forward-facing seat with a harness for as long as possible, and then transitioning to a booster seat. So what did it look like? This is what the screen looks like. So the parent downloads the app and answers a series of questions. In our case, we had the research questions, the data collection questions embedded in the app. But of course, if you're just using it for educational purposes, then you wouldn't need the research component. But in any case, so this is Elmo. Elmo's mom or dad answers how does Elmo ride in the vehicle most often. They answer that question. They click on to a bunch of other questions, and at the end, they get their feedback also on their phone, on their app. And this is the Elmo's car safety report, and we always start with what you told us, and then what experts say and what they should be doing. Again, using the algorithm that I showed you in the matrix. And then finally, the end of the report looks at each of those 4 behaviors. So you can see that Elmo is not in the best seat for him. Read why here, and you click there. Way to go, Elmo is in the right place in the car. Learn more here, gets a check. Check, keep it up, Elmo's buckled every time. Learn why here. And then another X, caution, Elmo's seat, I should say, has not been inspected by a car seat expert. Check here what to do. So this is the summary across the 4 behaviors. And I'm going to go into the actual study right now and how we evaluated it, but I can take a pause if anybody has questions about the intervention part.
How did you get the personalization for the child's name? Was it when they enrolled in the study, or did you pull it out of like ED records? Or?
No, it was when they enrolled. Yeah, when they downloaded the app. Yeah.
I'm curious, did you work with a design firm who actually made the graphics and all that stuff?
Mm-hmm. Yeah, there's a company that we've worked with for a long time that does apps and all of that. Yeah, all that stuff that I still don't know.
How many family members you involved in the education?
Oh, I'll get to that. That's in the study design. It's hundreds. So hang on one second, please.
Is it just a one-time assessment, or will you do it repeatedly over?
Yeah, great question. A lot of these are one-time activities, like our kiosk was one time, but this has text messaging in it. So there's a series of text messages at, I'm going to get the months wrong. I think it's like 1, 2, and 5 months. Where they get a text message that asks them to interact with the tool again and to use the portal. And so if they interact with the tool again, they get asked a much shorter list of questions based on what they were doing when they were in the emergency department to see if, for example, if it was Elmo, when Elmo clicked on the text message, Elmo would get asked about what car seat is Elmo in now. And then again, it would cycle through the messages. And there was also a portal. So it was as many times as the parent wanted to engage, and we haven't looked at those data yet, but we have them. That's another thing. In addition to the algorithms, this tool can give you all the data you could possibly want about engagement with your messages.
Was it built for iOS or Droid? Was it built for iOS or?
Oh yeah, either Android or iPhone.
You might have said this, but can you say where the kiosks were?
The kiosk was also in the emergency department, but there was no kiosk. Yeah, right. Yeah. Should we go on? We probably have more. All right. So the rest of the research. So we did a randomized control trial in 2 sites, the emergency department at Arkansas Children's Hospital and at ours in Johns Hopkins. And this shows you the eligibility and the numbers. So we'll answer your question. We enrolled 569 intervention and 560 control. To be eligible, the parent, or it was a parent or guardian of a 4 to 7 year old. They only had to have a 4 to 7 year old. They didn't have to be bringing in a 4 to 7 year old into the ED. They had to speak English, have an Android or iPhone, travel by car at least once a week, and it wasn't a special needs child because special needs children have different car seat issues. And then the intervention, obviously, is about car seats. Another issue to think about when you're doing this is attention matching controls. So we developed the exact same thing for home fire safety. So the control group got hopefully a benefit, but they got the same amount of tailoring and information about home fire safety. So of those, we then did a 3-month and a 6-month follow-up. We ended up with 367 6 months in the intervention and 375 in the control group.
So was one hospital the intervention and one the control, or were there intervention and controls at each hospital?
The latter. That was randomized within each ED.
You had better follow up at the 6-month and the 3-month? Was there some incentive linked to the 6-month but not the 3-month or something?
I don't know if we increased the incentive. We may have, but you didn't have to have the 3-month to get the 6-month. So that was a decision that we made because we were, time was marching on, and what's your window on 3 months? So, yeah.
If you had people who had 2 kids in that age range, did you just ask them to pick one?
Pick the one you love most.
Yeah.
Oh, that's, yeah.
They couldn't do it for both.
This is a great question. We set it up so that we had one index child, and I believe they just picked the one who had the closest birthday, something like that. But the way the program works is, and this gets to your question too, parents were encouraged to use the app for all their children. So while we have these 300 and some that we're evaluating these results on, those are index children. But our data set has all the children and all the families who were in the trial, who also completed all the same questions about their car seat and home fire safety behaviors. if anyone needs a dissertation or a capstone, we're not that far away. And since my kids are in LA, I'll come out here. Really, we are drowning in these data. But so does that answer your question? Yeah. Okay. So the characteristics of the families you see here. The mean age was 32 in both groups. The kids were about 5 years old. Almost all of the people we intervened with were the female guardian or mother. And then about 60% to 2/3 were non-white, had more than a high school education, and were employed full or part-time. And we had half and half between the male and female children. And there were no differences here. So this is the first of the outcome data. And the way these work is we had the four behaviors here, the intervention and control, baseline 3 months, baseline 3 months. The statistical test here is a difference in differences. So what you're looking at is, did the change from 69 to 78, was that significantly greater than the change from 72 to 67? And you can see we had statistically significant differences that favored the intervention group for 3 of the 4 behaviors. And we can just take a second to look at what the baseline rates were, because I think that's also interesting and informative. So we have an issue with not having the correct seat. We don't have as many people in the correct seat as we'd like. We do have a huge percentage of people reporting that they're putting the baby in the back seat and buckling the baby or the child on every ride. And then you can see here the opposite. Almost none of the families were getting their seat inspected. So that's also interesting to think about in terms of the need and what you might do next. So this is the same setup, but this is at 6 months, again comparing baseline. And here you can see that the only significant difference was in the correct seat, with the intervention group being increasing significantly more than the control group from baseline to 6 months. So what did we do? Is that the end of the story? No, wait, there's more. What we did was, as you noticed, we lost people. And so in the end, the people you have are not the people you randomized, and there can be very significant biases introduced by that fact. So we used propensity scoring methods to adjust for attrition in the outcomes. And then conditional logit models were able to be run of the probability of adopting the car seat behavior that you see listed over here, still the same 4 behaviors. So these are the results where we adjusted for baseline behavior as well. So in addition to the differential dropout problem, we also adjusted for where they were at baseline. And what you see here is that at both 3 months and 6 months, the intervention increased the probability of being in the correct seat significantly. And in the 3-month outcomes, we also increased the reporting of using the back seat all the time. And having the seat inspected was significantly increased in the intervention versus the control group at both outcome points. So I can wrap up with some of our limitations, but let me pause and answer questions.
How much guidance did you give on how and where to get the seat inspected? Because it seems like a surprising increase even in the control group in that. Why do you think that, I mean, you have a significant difference between the groups, but why would that have gone up at all for anyone? That seems like a very high bar.
I know, I agree. And the only thing I can think of is that it was because we asked questions about it. We didn't give any information to the control group until on car seats until after the end of the study. For the intervention group, we referred them to, in Arkansas, they have one program for car seat inspections and installations, and in Baltimore, we had one as well. So we were able to refer people to those local programs, and then you can also refer people to the NHTSA website where you can put in your zip code and find a place. So I don't know. Do you have another idea?
I wondered if it was a service at either of the ED. I mean, for that age group, it's hard to imagine. You know, they're not infants, where that might be more salient for people. So it's hard to imagine anyone doing that. It just seems hard.
Well, there are different kinds of booster seats with different harness systems and different ways to fit them into the car. And I was surprised actually that there are misuse problems with booster seats. And one of the issues here is that parents were transitioning to seatbelts too early. So the booster seat could be a foreign concept to them. You know, my kid's in a seatbelt. What are you telling me? I need to go get a car seat with this harness thing? And so there's more of a need than I initially thought. Any other questions?
Did you just, two questions.
Uh-huh.
To your point about the transition time period, as kids get older, obviously, parents think that they're probably size-wise able to do the seatbelt. Have you done any sub-analysis of that older population of like the 6, 7-year-olds and whether their outcomes were different?
No, we have not. This is what you see is what we've got. We're, like I said, have a lot more to do, but that'll be really good to look at. Yeah.
And then I guess the other question was, how did you get around if they? My understanding is when you would have your control group, they would answer questions about whether they were in a car seat as well, correct?
Mm-hmm.
So how did you get around kind of the ethical consideration if you're identifying kids who are not in a car seat at all, perhaps, or in a wrong seat, and yet not telling them for your control group?
Right. It's a problem that we have with a lot of the studies, and we treat it kind of differently in each study. And in this one, we did not give the control group intervention information until the end of the study, nor did we give the intervention group information about fire safety until the end of the study. It's a decision that just has to be made on each individual study. Just as a sidebar, we just finished a safe sleep intervention trial where we had 2 follow-up points. I have no idea why we said we'd have 2 follow-up points, but we did. And so when we went into the home to do observations of where babies were sleeping, we're not leaving if the baby's not in a safe sleep space, right? And so we ended up doing a little mini booster and new mini intervention in the home. And so now we're looking at our second follow-up going, well, what are we actually testing here? Because now everybody, one group has 2 doses and one group has a mini dose. So it's something to think about with all these intervention trials. You get these issues all the time. Mm-hmm.
So before the parents sign the consent form, we, the researcher, need to explain the study to the parents.
Mm-hmm.
So you will deliver the same information to the 2 groups or different?
On the consent process?
Yeah.
Yeah, no, in the consent process, and maybe this helps a little bit with your question. In the consent process, we explain the 2 groups and we explain what randomly assigned means. And so we say you will, like with a flip of a coin, you will be put in either a group that is going to get car seat information or a group that's going to get home safety information. At the end of the study, both groups will get all the information. So, you do have to explain everything. Anything else? Okay. So just to wrap up, these are some of the limitations and strengths that we thought of. I'm sure you can help us think of some more. Mainly the self-report of the child's weight and the parent's use. That's always a problem when you can't do observations. However, I would say that some of the things you want parents to do are only self-reported, unless you're going to put a video in their car. If someone says, I do this all the time, you have to do self-report. So it's not a fatal flaw, and it's very consistent with what other interventions have done and do. So the child's weight issue is another one we'd like to look at a little bit more, because when we did the baseline, they were in the ED and we actually got an actual weight. But then when we did the follow-up, it was parents' report of the weight. So there's some issues there.
Did you compare in the ED how accurate the parents were?
I don't believe we've done that yet. We may not have asked them on baseline since we had the measure. I have to go back and check. And we are also limited to only an English-speaking audience. And I would just say we have a growing Hispanic population in Baltimore. And as much as we would have liked to create a Spanish version, the amount of formative work that would need to go into that before you could even get to what the message should be was way more than we could afford. I mean, because you can't just translate it. So we had a few people who were Hispanic but English-speaking, but not very many. And then the loss to follow-up, we've already talked about using the propensity scoring to adjust for that. So those were some limitations that we had to deal with. In terms of some strengths, we think talking in the literature about thinking more carefully about what behavior you're talking about. There are multiple components to car seat behaviors, and you saw how how there was variation in the rates across, having it inspected versus putting it in the back seat all the time. So it helps you focus your intervention messages much, much more carefully. We also found that the 3-month, what I showed you was the data from both sites combined. When we looked at the two sites separately, the 3-month outcomes were consistent across the sites, but the 6-month outcomes were driven more by Arkansas, and we're starting to look into that as well. And then I really think, and I said this at the beginning, I think this technology allows you to talk to an individual, but in a large population efficiently. So I think we have to get it right, because there's, everyone is technologically savvy, except some of us, but that's how people are getting their information now. So I think we do have to figure it out. Yes?
Do you have any thoughts this side of the RCT about minimizing loss to follow-up in a design like you have?
Well, I would be open to almost any ideas. We text, we call. If we're doing home observations in the other study, we do drive-bys. We increase the financial reimbursement as much as we can. I think the other thing that we didn't do that maybe would be more product distribution, like our families really like in the Safe Sleep study, they really like getting a sleep sack, for example. So if there are ways that we could think creatively about when you're not doing a home visit, how do you incentivize people to respond to your text messages? I'm not sure if anybody has good ideas. Yeah, there you go, the tech side. No offense.
I have 2 questions. One's a follow-up to that. I guess, was there any effort to engage some of the big names of producers of these products to try and get sponsorships or things like even free coupons? It might be a pie-in-the-sky idea, but I feel like they might bite on that. And then the other question was going to be if there were efforts to engage those kinds of companies to kind of dig into their product research or their consumer research, because they're doing research on these people, and they probably have, if there's not a lot of research doing stuff like this, there's probably a wealth of knowledge that they have that they might be willing to share or help you leverage.
Maybe, yeah. I think that those are both great ideas. I don't know how proprietary they keep their marketing data, but it's, what would be nice is if we could partner with one of them now that we have these results and have them help us make this not researchy, but more parent, even more parent friendly and sort of put it out there. But then you have to be careful. You're not endorsing them, and they would a lot of places would like to use your name, right? They'd like to say Colorado School of Public Health endorses this. So it's hard, but with the funding climate, it's a great idea. Yes.
Did you, so when you say an app, was this like an app you had to download from a Play Store, or was it a website that was mobile enabled?
No, it was not a website. It was an app that you download from the App Store.
Okay. And I'm curious if you have thoughts about the one versus the other. I mean, it feels like an app probably you can better control how it's going to look. At the same time, having very recently had a terrible phone, I had no space, so I never wanted to download apps. So I'm wrestling with how you decide one way versus the other.
Right. I don't know that there's a right or wrong answer. I think it's knowing what your resources are and what your audience is interested in and capable of. I don't think we noticed much. I mean, I don't know. We could ask the others, but our kiosk was the other kind, where it was web-based and you just interacted and that kind of thing. But this one wasn't. So I don't know. I don't really know.
Next one. I'm curious whether in this or in other things, do you know if there's been work for sort of messaging for parents about how to talk to, for example, their 7-year-olds? Because I feel like the peer pressure thing starts in, and my friends are in a booster, or why do I, that how parents should talk to their kids about why they're still in their car seat.
Oh, that's a great idea. No, we didn't. That's a good next study to do. Yeah. Well, I think one thing we might do. No, that won't work. Okay, sorry.
I was wondering, did you find any differences between white and non-white population with regards to misuse rates, especially in the intervention group?
No, we haven't. We have not looked for those differences. The two groups weren't any different at the outset, and we adjusted for whether they were demographically different at the follow-up. But we could definitely dig into the data more and look at that. Did you?
I had a question that's similar to that. I wondered if you saw any impact or differences by the parents' age and by their seatbelt use practices.
No, we don't. I don't think we have their seatbelt use, and we just controlled for age. Yeah. So again, we could, there's a lot we could dig in here and do. Mm-hmm.
So you mentioned a little bit, it's not simply translate the language to Spanish or other languages when applying to other ethnic groups. So when trying to apply it to different ethnic groups, what's your concerns or other things we need to consider to apply the same information to different?
Well, I think we're firm believers in formative research. So starting out by getting to know your audience and their beliefs and barriers and facilitators, experience with the behavior, how they like to get information, those kinds of questions. I mean, you really need to do formative work before you decide what you're going to do. Yeah, I didn't talk about it. We did a number of interviews, and we showed drafts to parents, and we did all of that development work at the beginning, which I should have mentioned. Oh, sorry. Let me. Okay, Daz, what?
Andrea, I was just thinking about how many apps fill people's phones in space and time. I'm wondering, it seems like in some sense this app is a one trick kind of thing, and a new parent probably has issues about feeding and I'm just wondering if there's a way to have an app that kind of pulls in or cycles through a bunch of different topics over time, so that you may get this baseline and then months later, but in between there would be things that would help you with advice on other things. It strikes me that it's a lot of kind of space on your screen for one topic that's relatively short in existence, and whether you keep it on your phone or it seems like kind of but it uses a lot of space for a relatively small piece.
It's a lot of work for yield on one or two safety behaviors. I agree, but I think it's the platform and the process that we went through is what's going to set us up if anybody wants to fund us to build it out just that way, so that you would have the app and you would click on car seats, or you would click on smoke alarms, or you'd click on nutrition. I mean, we'd probably just do injuries, but you could do. That's the idea. That's what we kind of want to do, is actually build it out like that.
It's kind of like where McKinsey's at, right? Where it's got a house and you can go through places of the house and learn safety information associated with those rooms.
Right.
But it doesn't go into as depth of information for the parent to know
Right.
what they're doing now.
Right.
The two could be merged.
Yes, we could.
I was just thinking about a place like Baby Center on the web that has advice on lots of different topics in child behavior. And so if there was a way to kind of, even if it just rotated so that when it updated your app, it kind of moved into a new module and was programmed to do it. It just seems like, thinking as a pediatrician advising parents,
Right.
they have lots and lots of questions about lots of different topics.
Well, and that's a great idea, because we always are guided by what the American Academy of Pediatrics says in terms of what we say, obviously. So if they could use a tool like this, we could build it out for them, and it could be in every pediatrician's office in the country. But I don't know what they're doing with messaging, but I think that's a great idea. And I don't know Baby Center, but I'll look at that too. Yeah, that's a great idea.
Time for one more question.
Yes, did I miss you?
Yeah, well, you somewhat answered it when you were just talking about the development and doing parent interviews. I was curious if you had gotten any qualitative feedback from parents, either prior or from your trial, those parents, and what they had thought about it.
Yeah, we didn't. I think we asked some satisfaction questions in our data collection, but we haven't looked at those yet either. But all the qualitative stuff was ahead of time. Yeah. Did we have one?
One last, and then I think there's probably a group trying to get in the room.
I was wondering, how do you guys feel the health literacy was with you guys, especially that first screen that had all the different crises?
Right.
Did you end up having to explain a lot of the crises to them, or how did that go?
Right. No, we did literacy testing on everything. I should have said that. Even with the kiosk study, it was at 8th grade reading level or below, I believe, maybe even 5th. I'm not 100% sure. But yeah, we did look at that because that's real important.
Well, with regards to the actual car seat types, because I know some parents don't know.
Oh, we showed pictures. Yeah, we had pictures. Yeah, you can use pictures. So there they are. And there's me if you want to reach me, and here's some publications. So I can leave the slides with you.
Yeah, well, the videotape will be posted on our website in about 2 weeks on the Piper website, so you can see it there.
Okay.
All right. And thank you all for your questions.
Yeah, thank you. And you're good suggestion. I'll maybe come back.